Postoperative nausea and vomiting, or POMV, is a common side effect of general anesthesia and it affects approximately 20 to 30% of patients. This is an adverse effect that can lead to longer hospital stays, unfavorable outcomes, and overall patient dissatisfaction and discomfort. A common treatment that has been found for the prevention of PONV is Ondansetron. Anesthesia providers administer Ondansetron at different times during the perioperative period. The phenomenon of interest is whether preoperative administration of Ondansetron or administration just before emergence leads to a decreased incidence of PONV.
The Iowa model was the theoretical framework used to guide the research process. The occurrence of PONV and the inconsistency of ondansetron administration timing among anesthesia providers was the problem-based trigger that initiated the research process. A PICO question was developed to address the relationships between PONV and two common methods of ondansetron administration timing. A team of 2 doctoral nurse anesthesia students was formed to search, appraise, and synthesize the literature related to this topic. A review of the current literature demonstrated that there was insufficient evidence to support a practice change. As recommended by the Iowa model, evidence from other sources should be used to guide clinical practice until additional literature is available.
The object of this systematic review was to develop recommendations regarding when to administer Ondansetron according to the current literature. The recommendations can be utilized in nearly every general anesthetic to help reduce the incidence of POMV and improve patient outcomes. Search strategy criteria were developed by 2 doctoral nurse anesthesia students focusing on types of participants, interventions, comparisons, and outcomes. The search criteria for participants included keywords like young female, non-smoker, and patients with a history of PONV. Search criteria for interventions included keywords preoperative Zofran, prophylactic Ondansetron, and prophylactic Zofran. Search criteria used for comparison included the key terms Zofran prior to emergence, prior to wake up, and prior to extubation. The search criteria used for the outcomes included key terms such as decreased nausea and vomiting in PACU and decreased aspiration. A systematic exhaustive literature search was performed using the Preferred Reporting Items for Systematic Reviews and Meta-Analyses, or PRISMA protocol. The Medline, Embase, CINAHL, Ovid, ProQuest, Cochrane, and Google Scholar databases were all used during this process. The exhaustive literature search yielded a total of 3 studies published between the year 2017 and 2023. Of these 3 studies, 2 were randomized double-blind controlled trials, or RCTs, and 1 was a quasi-experimental study. Of all the studies, 2 major themes were identified among these articles. First was preoperative versus intraoperative ondansetron and inhalational anesthesia, and the second was preoperative versus intraoperative ondansetron and total intravenous anesthesia, or TIVA. The studies contributing to theme 1, preoperative versus intraoperative ondansetron and inhalational anesthesia, indicated that there was not a substantial decrease in the total occurrence of PONV when ondansetron was administered preoperatively. The studies supporting theme 2, preoperative versus intraoperative ondansetron and total intravenous anesthesia, suggested that the preoperative administration of ondansetron may not decrease the incidence of PONV when compared to its administration just prior to the emergence of anesthesia.
Information from all 3 studies was synthesized to determine the conclusion of the evidence. The current literature provides conflicting evidence regarding the relationship between the timing of ondansetron administration and the incidence of PONV during the first 6 postoperative hours. Therefore, the optimal timing of ondansetron administration to prevent PONV in the first 6 postoperative hours remains unknown. However, the evidence did support that beyond the 6th postoperative hour, the incidence of PONV does not vary regardless of the preoperative or intraoperative administration of ondansetron. Some of the limitations and challenges of the studies included in this systematic review included vast differences in the geographical location, culture, and approach to healthcare. All 3 studies utilized small sample sizes from single hospital sites. Most of the participants included in the studies were females, which may limit the applicability of the findings to a larger population of patients at risk for PONV. Different doses of ondansetron were used across each of the studies. A standardized PONV risk score was not used in each study for comparison. A control group was not included in any of the studies due to ethical concerns, and one of the studies experienced data collection delays due to the COVID-19 pandemic. The strengths of these studies include that all of the studies received approval from an ethics committee and were published in a peer-reviewed journal. There were no reports of conflicts of interest or outside fundings for any of the studies in this review. The study designs included 2 randomized controlled trials and a quasi-experimental study, both of which are associated with high levels of evidence. Each of the studies collected and evaluated baseline participant characteristics. The randomized controlled trials included in this review were also assessed to have a low risk of bias. The summary of current evidence supports these recommendations. The current literature does not suggest that one administration timing method is superior to the other. Ondansetron is a safe and commonly administered antiemetic that has a well-documented efficacy for the treatment and prevention of PONV. Thus, both the preoperative or intraoperative administration of ondansetron are appropriate methods to prevent PONV in high-risk patients. Factors specific to the patient and the surgical procedure should also be considered when determining when to administer ondansetron. The synthesis of current literature suggests that there is insufficient evidence to support one method of ondansetron administration timing over the other. Thus, a practice change should not occur based on the current evidence alone. As the incidence of PONV did not vary after the 6th postoperative hour, either method of ondansetron administration timing is appropriate to prevent PONV in the first 24 postoperative hours. Until additional literature is available, the timing of ondansetron administration should be determined on a case-by-case basis. Some of the factors that should be considered when determining when to administer ondansetron include patient-specific risk factors for the development of PONV, surgical procedure risk factors, and the pharmacodynamics of ondansetron. The inconclusive findings from this review suggest that additional research is necessary. Additional studies must be conducted to fully evaluate the impact that the timing of ondansetron administration has on the incidence of PONV. The inclusion of large sample size, multi-center, randomized controlled trials may provide a more comprehensive investigation of the phenomenon of interest. Studies with larger sample sizes may also provide a more diverse group that better represents patients at high risk for the development of PONV. Future studies should address the limitations of previous studies by incorporating a standardized risk score such as the APVEL scoring system to quantify the PONV risk of each participant.